Uh, Good evening, everybody, and welcome once again to the teaching session of Department of Urology, Savai Mansingh Medical College, Jaipur. We are almost approaching our golden jubilee, right? This is probably the 47th or 48th webinar consecutive of our teaching session. So today we have a very renowned faculty. Is Dr. S.S. Vasan, and I would just probably, he doesn't need an introduction, but formally I would introduce him. Dr. S.S. Vasan, he is CEO and Medical Director of Ankur, Bangalore. He is also head of the Andrology Fellowship Program. He is a teacher at Rajiv Gandhi University for Health Sciences. He is the co-founder of Janani program, which is a startup transforming fertility management. He is presently the president of South Asian Society of Sexual Medicine. He is a member of the Stem Cell Task Force in Indian Institute of Science. He has many innovations to his credit, and he has he also is involved in many of these sexual dysfunction projects in like ED and male infertility and app for male medical management. So thank you, sir. Thank you once again, Dr. Vasan, for being part of our program today. And so I would now request you to kindly start your presentation. Yes, please.
Thank you, Shivam. And thank you, SMS, for this opportunity. I hope you are able to see my slides.
Yes, sir. So a bit louder, please. Plus, that's all. Yes.
Sure. Yes. I'm going to take you through management of azoospermia. These are basically clinical presentations. And so you feel free to interrupt whenever you feel, because these are case scenarios. I'm sure it would have been more interactive if we are seeing each other. So this is a new format. So let us see how we go about this. There are a lot of slides, so I will try to rush in. Basically, we are all looking at, we all know that we require one healthy and a lucky sperm which swims into the cervix, which approximately is 1 in 100 chance. And we know that the sperm travels through the fallopian tube to the isthmus, where it will meet the oocyte, which is released from the ovary. And then the process of the sperm entering the oocyte happens. And then we all know that the embryo, which travels to the uterus and implants in the endometrium. This is the rough process, but it's quite challenging because at many instances, it is not so simple. So just give me a minute, just 1 second. My dog is barking. I have to just 1 second.
Sure. Go ahead. So in the meantime, I would request all the residents and faculty members to kindly put their videos on, and any query, anything, you can just raise your hands or just put it in the chat box, so that it will be more of an interactive sessions, because it's a case discussion. So thank you, sir. So go ahead, please.
So just to define what is azoospermia, we all know that azoospermia means that there are no sperm or seen in the semen. And when you look at what is the incidence in the general population, it's 1%. But when you look at infertile men, it varies from region to region. Obviously, some regions have more, but you are looking at a 10 to 15% of men with who are infertile having azoospermia. But the challenging aspect is that we all should understand azoospermia can be transient in some men. There could be fluctuating sperm count. That means somebody can become azoospermic suddenly and then have normal sperm count or subnormal sperm count. And you can also have cryptozoospermia. So consequently, cryptozoospermia is very few sperm in the ejaculate. So you require multiple reports over time, and you need to centrifuge the sample and examine the pellet, which is the basic ethos of confirming azoospermia. So what is the first step which we need to take if a semen analysis suggests no sperms? One is, we know that WHO now recommends an examination of a centrifuge sample at 3000 G for greater than 15 minutes, because even a presence of small number of spermatozoa in the centrifuge sample is classified as cryptozoospermia, because you can freeze those sperm and use it for an advanced procedure like an ART. Only if no sperm is observed in the centrifuge sample, then you classify it as azoospermia, and typically you require at least a minimum of 2 samples which represent similar picture, then you classify him as azoospermia. So I'm going to take you through a couple of scenarios where we have azoospermia. Here is a 29-year-old male who comes with primary infertility of 1.5 years duration. He's a bodybuilder by profession and has been using food supplements and medications which we don't know to improve muscle mass for the last 3 years regularly. He comes with a semen analysis which shows a volume of 3 ml, which is normal, a pH which is 7.8, which is alkaline, and the semen report says that the seminal plasma has no sperms, which is azoospermia. His FSH, which was done outside, shows 1.5 MIU per ml, or international units per ml, and testosterone is in the high normal range. Because testosterone varies from place to place in terms of reference ranges, we will just take it as high normal. So in this case, what would be a diagnosis as the causative mechanism for azoospermia? It most likely would be because he's been using supplements for bodybuilding, and we know many of these men use some supplements which can suppress steroidogenesis and or enhance steroidogenesis and consequently suppress spermatogenesis. This could be a case of iatrogenic or testosterone-induced azoospermia. So to understand this case, so my first case is a presentation of a drug-induced azoospermia. So what is the role of testosterone? We need to understand what is the role of testosterone in the management of male infertility. Because typically we need to know what is the role of testosterone in spermatogenesis and impact of blood testosterone versus intratesticular testosterone on spermatogenesis, because this gives us a comprehensive way of understanding the role. So I'm going to take you through next couple of slides which explains the role of testosterone. As we all know, spermatogenesis consists of spermatogenesis as well as spermiogenesis, that is the total sperm cycle. And we all know that initially from the primordial germ cell, you have typically mitotic divisions. 3 times the mitotic division happens, which is the spermatogonial stem cell, spermatogonium, and the spermatocyte. And at this level, where you have the spermatogonial stem cell to the spermatogonium, you require influence of testosterone. And then you have the meiotic division, which is where the secondary spermatocyte, early spermatist, and then the differentiation, where the Sertoli cell provides nutrients to sperm, which is the spermiogenesis. So both in the early spermatogenesis as well as in the spermiogenesis, you have the influence of testosterone. So just to look at spermatogenesis and Sertoli cell, how does Sertoli cell play a role? We all know that Sertoli cell are the basic nourishing cells for the testis. So they provide, these are columnar irregular epithelial cells having cytoplasmic appendages, and they're also called sustentacular cells or the mother cells. They provide nourishment and also aid in spermatogenesis. They create the blood testis barrier by formation of tight junction, and they provide structural support by forming adhering and gap junctions with all stages of sperm cell. And they also provide synthetic functions in terms of hormones, which is your AMH, inhibin, activin, androgen binding protein, plasminogen activator. And they're also the cells for the receptors for androgen and FSH receptors. There are several functions which the Sertoli cells do, which is also additionally, they are also involved in phagocytosis, tubular fluid synthesis, osmotic gradient. So all this is aided by the Sertoli cell. And that's why there was a belief that Sertoli cell are critical. And if you don't have Sertoli cell, you have what is called Sertoli cell only syndrome, or you have only Sertoli cell and other cells are missing. There was only Sertoli cell only syndrome. And consequently, they may not be able to produce sperms at all at one point in time, which is now, we know that is not true. So the duration of this whole sperm cycle was earlier supposed to be 90 days, then it came down to 76 days. Now we believe it is a cycle which happens between 56 to 64 days. depending on the speed of spermatogenesis. So the stages of spermatogenesis are, there are two types of spermatogonia, which is type A and type B. In type A, you have AD and AP, and approximately 512 spermatids are formed from a single spermatogonium. During divisions, the cells are bound to each other by cytoplasmic bridges for synchronized development, and this is called incomplete cytogenesis. And the whole stages are spermatocytogenesis, spermatogenesis, spermiogenesis, spermiation, and maturation. So these are the various stages of the sperm cycle. As you can see here, these are the spermatocytogenesis, spermatidiogenesis, spermiogenesis, spermiation, and then the maturity, which is the spermiogenesis and those kind of cycles which are necessary. And this is the way the sperm cycle develops in the human Sertoli cell, as well as aided by the Sertoli cell in the seminiferous tubule. And in the spermiogenesis cycle, that is after the stage 4, where you see spermiation or spermiogenesis, you have in this spermiogenesis cycle, you have the spermatid formation, wherein the nucleus forms, then the centriole forms, then the microtubule and flagellum, early flagellum forms, then you have the mitochondrial and the full flagellum formation, then there is exudation of the excess cytoplasmic reticulum, and then you have the acrosome and the nucleus, and then the formation of the full sperm, which is the mature sperm. So one is the maturity of the sperm, and this is controlled, the whole spermatogenic cycle is controlled by the hypothalamus, wherein you have the GnRH, which acts on the, which is the hormone secreted by the pituitary, hypothalamus acts on the pituitary, and then you have the FSH and LH. LH acts on the Leydig cell, and FSH acts on the Sertoli cell, and then you have the androgen binding protein and the inhibin, which has a negative feedback mechanism on the pituitary, and again Leydig cell produces testosterone, and this is the peripheral testosterone. This is the intratesticular testosterone, which then differentiates into dihydro. This is the intratesticular, this is the intratesticular, and this is the peripheral testosterone, which diverges into dihydrotestosterone and estradiol, again, which has a negative feedback both on the pituitary and the hypothalamus. So all of us are pretty much aware of this is the basis for understanding spermatogenesis, spermiogenesis, and the hormonal control. And the mechanism of testosterone acting on these is when you have the LH, which is gonadotropin regulated, as I said, from the hypothalamus and the pituitary, and then it acts on the testis, and the testis produces testosterone. Then the testosterone internally has this kind of an action where it can get degraded into by 5-alpha reductase into dihydrotestosterone, or it can act on the target cell, and it has a several role on spermatogenesis, sexual differentiation, Wilfian stimulation, external virilization, and sexual maturation at puberty. So this is the complex mechanism. So as we all know, testosterone is a primary hormone both for pubertal as well as for spermatogenic or reproductive organ development. And it also has some effects on the liver, red blood cell, muscle mass, skeleton, larynx, and so on and so forth, because it has multitude of action. So what is the basis of sterility in steroid abuse? As we all know, this is the normal phenomena where the hypothalamus and the pituitary secrete LH, and then you have the Leydig cell, which gets stimulated, and there is high intratesticular levels of testosterone, which acts on the Sertoli cell, and which then acts on the androgen binding protein and facilitates spermatogenesis. As we all know, the intratesticular testosterone is approximately 100 times or 1,000 times more than the peripheral testosterone. Whereas what happens in a steroid abuse is that because of the steroid abuse, increased circulation, peripheral circulation of testosterone, there is exogenous androgens enter the circulation and exert excessive negative feedback on the hypothalamus and the pituitary. Consequently, hypothalamus and the pituitary get suppressed, because of which the Leydig cell is low, LH is low at all lower than the normal levels. So there is less stimulation of the Leydig cell, lowered intratesticular testosterone, consequently insufficient spermatogenesis. So this is where exogenous androgen which a patient or a male consumes for various reasons has a negative feedback inhibition on the whole process of spermatogenesis. So this is a significant effect. So what happens in this case, if you see a case which is like this, first is, what do we do for this individual? What is the expected time needed for spermatogenesis to come back to normal? There are various groups which have studied this, but there is no consensus on the exact timeline because it can vary from individual to individual depending on the level of suppression and the level of receptor responsiveness. So consequently, the minimum time limit which is required for spermatogenesis to normalize is approximately 2 to 3 spermatogenic cycles. And if we consider 60 days approximately as a spermatogenic cycle, you're looking at 4 to 6 months for a minimum time limit, which is extended to 12 to 18 months at the upper limit for normalization of spermatogenesis, depending on the amount of suppression, as I said, and the receptive responsiveness. So that is the first scenario where we would see an individual with drug-induced azoospermia. And of course, there are strategies in that phase. Just to go back, the spermatogenesis can be hastened to normalize by giving supplemental stimulation of the gonadotropic axis. As I just explained, we could add LH to these individuals to normalize, but after waiting for 2 to 3 spermatogenic cycle for normalization of spermatogenesis. The other case is a 37-year-old.
Dr. Vasan, can we just stop here, or maybe if we can ask some residents or faculty if they have any query regarding the case 1? Yes. So I think you very rightly started with this case because this is becoming a very common case scenario where people are taking more of these steroids, anabolic steroids and testosterone for bodybuilding, and then they are coming with azoospermia because of this low intratesticular testosterone. So yes, there is one more that some would also do a 17-hydroxyprogesterone level to estimate this intratesticular testosterone. What do you think about estimation of 17-hydroxyprogesterone?
Yeah, we have started this recently after I spoke to Ranjit. I think Ranjit has worked on this.
Right.
And we did start on this, but we are still not able to find an exact correlation, because sometimes you would find the peripheral testosterone to be high, but intratesticular testosterone, 17-hydroxy to be low. So we are not sure. We have tried to also raise this level of testosterone in those individuals where we have found lower levels of 17-hydroxyprogesterone, but we have not seen a great clinical benefit. But of course, our volumes are very little. We have done probably about 30-40 cases where we have tried this. So we have still not been able to standardize and conclude that the basic point is whether we should abandon doing total testosterone totally and stick to only 17-hydroxyprogesterone, whether it represents a better value in terms of management. I'm not sure at this point in time. I think this is an evolving field. Maybe if any of you have better idea on this, you can throw some light. But at this point in time, I'm doing both, trying to correlate whether I can find a significance. Ultimately, if we are able to find 17-hydroxyprogesterone to be a better marker, it would be very useful to go with an intratesticular testosterone value than a peripheral testosterone value. And also, standardization of testosterone in terms of biochemistry has always been challenging in various groups reporting how to do testosterone assay. And that has been a major problem for all of us in testosterone assay, where we have dealt with several labs with testosterone. So in that sense, 17-hydroxy may be a better marker in terms of doing the assay, which is more standardized. But in terms of its value and predictability, I'm not still sure whether it gives the criticality in management.
So would you do a T ratio in these patients?
Yes, absolutely. Basically here, see, the point is here, it is the suppression of testosterone production intratesticular because of negative feedback inhibition. So it is not a question of T ratio, basically because intratesticular testosterone in this case is very low. So I'm not sure there is a relevance of a T ratio and giving aromatase inhibitor, because I don't think estradiol in these men will be very high, because their testosterone will be very low because it is suppressed. And T ratio would always come high in these individuals because their peripheral testosterone, which is what you are considering for T ratio, will be very high. So in fact, in these kind of individuals, if you do a T ratio, you will find always T ratio to be less than 10 because your peripheral testosterone is high, estradiol is low. So probably, I don't know whether there's a role of putting them on an aromatase inhibitor where you essentially not doing anything except you are trying to prevent some amount of conversion of intratesticular testosterone to peripheral testosterone, estradiol. But the challenge is to improve the central axis and improve the pituitary production of LH, which is more critical in these individuals.
So many of these drugs which they are taking may not be just only testosterone. It may be a combination maybe of all these hormones. So probably it might can result in some increases in estradiol. I do not know whether it's not a simple only just a testosterone, right?
I agree. Many a times we don't know how these drugs work also. That is the other challenge we have. Because many a times I have to do some research to find out what is this drug they are taking, because some of these are new. Some of them also take growth hormone. So it's very difficult to predict. So I guess this is a field which is evolving very rapidly, especially in sports medicine arena, where new drugs are coming in. People are treating, trying to enhance performance by various means, and we are also learning in the process.
So what would you give in this patient? You will withdraw the drug, definitely. You will wait for some time. If it's still the patient doesn't have this increased in level of intratesticular and it doesn't come, the semen still shows azoospermia, then would you give SCG injections or a clomiphene citrate or what?
I would prefer, I have always used HCG more than clomiphene citrate because you need much more stimulation in these individuals, which is direct. And that is what I have followed. There is a small group of individuals who still try clomiphene citrate. I'm not convinced that clomiphene citrate works in this individual, but it's a call. You can always give clomiphene, wait for some time, and then switch over to HCG. It all depends on how frustrated the patient is and what is the age group of the patient. My guess is if the testicular volume is good and if there is no other contraindicating factor, I would use an HCG style directly than giving a clomiphene citrate.
And would you add a FSH later, or it will just only a SCG?
See, the point is, in this case, we very well know that many a times the suppression is only of the LH. But if you have evidence that FSH is also suppressed, then definitely I would add HMG, FSH at a later date. Once I know that if there is no response only to HCG, maybe with 8 to 12 weeks of stimulation, then I would add an FSH.
Right, because FSH was quite low here, 1.5 only. So maybe.
Sure.
Right. Okay, thank you. If any resident has any query, did you understand the scenario? All of you? Just one of you, just unmute yourself and just say anything. So if you have understood everything, otherwise just ask, because this is a very nice opportunity to ask any query because Dr. Vasan is such an experienced person in male infertility. He is he is a teacher, and he is a person who also runs a fellowship in andrology program. You can always interact with him later also. So any of the residents, if has any query, please come out, right? Okay, thank you, sir. Dr. Vasan, go ahead with the second session. Yes, please. Dr. Gagan, do you have anything to say?
Yes, sir. How often should we get the semen analysis done, and how long should we wait before starting HCG therapy?
Like I said, I prefer to do semen analysis after one spermatogenic cycle. So earlier concept was wait for 3 months, but nowadays we do it at the end of 8 weeks, because that would complete about 60 days of treatment. And we would also repeat the hormones at that point in time to see whether we have made any difference, whether there has been any, the suppression has come down in terms of whether the LH has improved. And it's HCG therapy, like I said, I would wait for the natural response at least for 2 cycles. If the patient is very anxious, I will start at the end of 2 cycles, which is 4 months. If the patient is not anxious, I would typically wait for at least 6 months.
Right, sir. So please go ahead with the second, sir. Yeah.
So the second case is a case which is also commonly seen, a 37-year-old male patient who comes with primary infertility of 9 years duration. His semen analysis shows low volume. We know that typically now the volume is less than 1.5. Now the latest WHO 6 draft says that the volume less than 1.1 is abnormal. pH is acidic at 7, and he shows azoospermia. So typically here there is a normal testis, no evidence of varicocele, FSH is normal. So what are the presumptive diagnosis in this case? So we have a scenario of an acidic pH, low volume with an azoospermia. Of course, I have not given you clinically what is the palpation evidence, except that I've said the normal testis. So most probable scenario in this case is a distal ejaculatory, ejaculatory duct issue. So that is what it represents because the volume is low, pH is acidic. That means the seminal fluid discharge contributes a significant amount to the pH alkalinity. So seminal fluid is missing. So possibly low volume acidic samples, you are looking at CBAVD or bilateral complete ejaculatory duct obstruction. Now bilateral complete ejaculatory duct obstructions are rare. Typically, you don't see very many of them. So the more common scenario is a CBAVD, and bilateral complete ejaculatory obstruction, though it is bilateral, still because of the prostatic component, you will still have seminal fluid, and it will not be, it doesn't mean it's a dry ejaculate. So when you have a normal volume alkaline pH, you classify them as spermatogenic failure or an obstruction at the level of proximal vas or at the epididymis. But a low volume acidic sample, you are typically looking at a CBAVD or a bilateral complete ejaculatory duct obstruction. So this is what is the classical picture, where you have the site of obstruction can be in the vas or in the epididymis or in the ejaculatory duct at this level. It can be at the level of the seminal vesicle entering the ejaculatory duct or distally after the seminal vesicle enters the ejaculatory duct. If the seminal vesicle component is missing, then the semen fluid is likely to be acidic because it has more of the prostatic component. So that is the concept. And volume also is less because significant amount is contributed by the seminal vesicle. Whereas if it is an obstruction at the vas deferens or the epididymis, the pH will always be alkaline and volume is not compromised. So that is the concept. So fructose negative, and of course the typical picture I didn't give you in this is what is the fructose level. Usually we do, of course, you have quantitative and qualitative assessment of fructose, and we don't do quantitative anymore. We do only qualitative assessment. That means we use the Selivanov and just tell you whether fructose is present or absent. And we know if fructose is positive, it could mean anything. It could be a failure or it could be an obstruction. It's a diverse picture because it can be either. Whereas negative is more significant, because like I told you just now, explained to you, negative means the fructose also is contributed significantly by the seminal vesicle. So it is vas aplasia or ejaculatory duct obstruction. So that is what it is. And the causes of obstructive azoospermia are several. So one of the causes is CBAVD. So in an obstructive azoospermia, fructose becomes important because if fructose is negative, then your suspicion comes down to only CBAVD or ejaculatory duct obstruction. If fructose is positive, it rules out CBAVD or ejaculatory duct obstruction. It is the other entities which are shown here. So in this, what are the clinical findings you will look for? You will look for any operative scars. You will look for vas typically because vas will be absent. Very rarely you can find an atretic vas in individuals, or sometimes you could even have a unilateral vas, and epididymis is usually full, and seminal vesicle by PR can be examined, wherein you will feel a boggy seminal vesicle just lateral to the prostate. So it is something which you can observe. So what are the other investigations you ask for? Typically, you can confirm this CBAVD by a good transrectal ultrasound. And of course, in a CBAVD, we need to do an assessment of CFTR gene mutation. And also, basically because the risk of CFTR gene mutation is very high in a CBAVD, though it is low in an Indian population. And if it is, you're looking for a CFTR gene mutation, partner assessment, if you're going to proceed with any procedure to try to create a child, is very important, because that this is a transmittable phenomena, and consequently you would look at a partner assessment also. And there is an important role of genetic counseling in CBAVD, where we need to explain to the couple what are the implications of the CBAVD if it is transmitted, CFTR gene mutation, if it is transmitted, because not all mutations are accessible or tested in India. We have almost 55 mutations, and after which only 27 we are able to test at this point in time. Though the incidence is less, if there is a transmission of CFTR gene mutation to the child, it can be disastrous because of the lung complications it can cause. So what is the treatment modality in this kind of an instance? Because once you confirm it is CBAVD, there's no question of a surgical intervention in these individuals. So the best option in these cases is, like I said, to go ahead with making sure that you have ruled out any genetic abnormality or a genetic transmissible abnormality, counsel the individual on the genetic possibilities, and offer them a PISA or a TISA. The reason why I put a PISA or a TISA is that in terms of the embryo viability, in terms of fertilization rate, there is no difference between a PISA or a TISA in a CBAVD. So whatever is convenient for you, you can go ahead and do it. And the success rate and the fertilization rates are similar if a patient accepts. And also the chances of finding sperm in CBAVD in a PISA or a TISA is almost 98%. Very rarely you will not find sperm in a CBAVD. So that is the case 2 scenario. I'm sure there will be a lot of questions, because I thought I will present these 2 and move on to other case scenarios.
Right. So I would request again the faculty and the residents to come up with more questions. So to begin with, I would about the fructose estimation, because again, there are some debates about fructose estimation. One is that fructose may be even positive in some of these patients of congenital bilateral absence of vas, because seminal vesicle is not absent in every case. It may be hypoplastic or even present in maybe about 20 or 15-20% of cases. So fructose may be even positive in some of these patients who have absence of vas deferens. Secondly, because it is a low volume, most of the labs would not examine for fructose estimation. So how do you actually depend upon the fructose estimation in these patients? And secondly, about many of these patients, if they have hypogonadism, can also produce low volume ejaculate. So would you do a hormonal estimation before going ahead if the vas is palpable? And then, so first of all, about the fructose estimation, what is your comment?
Yeah, firstly, you are right, Shivam, because fructose normally, there are many instances where seminal vesicle can be rudimentary, seminal vesicle can be partially formed. So I do agree with you that is why you get sometimes a report of traces of fructose. It will never be a normal fructose estimation, but it will be a traces of fructose which is present in these individuals. So that is a scenario which you see. And secondly, as per volume and assessment of fructose, routinely now WHO doesn't recommend fructose assessment for all semen analysis. So the way it happens is, when you get an azoospermia sample, you get a sample which is acidic, and you get a sample with low volume ejaculate, and you examine the patient, and then you find that there is a suspicion of congenital absence of vas deferens. Then you ask for a fructose estimation, again of a repeat sample. It is not necessary that in the first instance itself they do fructose estimation, because in that second instance they are just looking for azoospermia and they are looking for fructose. And Selivanov test does not require much of semen volume to do the fructose assessment. Third, once you are convinced of a normal size testis and low volume ejaculate acidic, the chances of hypogonadotropic hypogonadism is low, which is my next case, which I'm going to present. But either way, for any procedure which you are going to do, especially in reproductive science, when we are proceeding, a mandatory FSH is always done for all individuals who are proceeding for surgery, because FSH has been some sort of a marker, though not a classical marker. It gives you an overall idea, especially when it is abnormal, what may be the possibility of spermatogenesis. So consequently, yes, you are right. Before proceeding to a definitive procedure, despite having a diagnosis, just like nowadays we do a COVID test for all individuals, I always do an FSH just for a confirmatory thing as to rule out whether there is something which I have missed in terms of like, let's say a variant of an azoosperm hypogonadotropic hypogonadism presenting with this kind of a form.
Right. So absence of vast difference is so obvious on clinical examination. So do you require any other test to prove it? Like even the fructose, whether it is done or not, it doesn't matter probably. If there is total bilateral absence of vast difference, it is so obvious that this is a case of CBAVD.
No, the only reason why I do is we live in an environment of litigation and a lot of things happening. So and many patients with this kind of a picture, they are always confused as to what is wrong with me. So these are all corroborative evidence for you to document in your finding, because the clinical finding you can't document. It is you against anybody else. So if you have a documented finding of a fructose negative, if you have a documented finding of a transrectal, it just strengthens your case, saying that you have done the things rightly. So it's for me, I look at it more from a documentation perspective, especially to confirm the diagnosis that I've done, because I can always report on a clinical examination VAS not found, and somebody else can report it as found. And that is a frightening scenario for me, because many of these patients shop around, they go to the next fellow. And if he is not a qualified doctor, and if he says, somebody says that your VAS is there, then you always have this challenge. So especially when I work in the private setting, I have found all these kind of challenges. So that's why. But typically, right, you're from an exam perspective, if you have documented there is no VAS, and obviously, if you're convinced that clinically there is no VAS, I don't see a rationale for doing a transrectal ultrasound also. You can always do a PR examination and save the patient the agony of going through a transrectal ultrasound examination, which is not a comfortable examination, and also avoid doing a fructose. Not an issue.
All right. So there is some confusion about the CFTR gene mutation also, like, because as you rightly said that we do not have all the mutations tested in the lab today. So exactly for the residents, I would like you to just slightly elaborate, because both the partners would be required to do this gene mutation test. And secondly, in the male partner, if it is a major or a minor mutant, that would also probably make a slight difference. And whether the female partner is a carrier or not, that would again make a difference. So a little comment on the CFTR mutation test.
I think, Shivam, you are the best judge for this, because I'm sure Shivam did a lot of work on this. Yeah. I would like you to clarify this more than me, because I think it should come from the expert, who is Shivam, more than in this case, because we do this quite often. But I would like to hear from you, Shivam. Go ahead.
No, so we do it both the partners, definitely. So I would like to know the resident should know that it should be done in both the partners. And if the female is a carrier, definitely we should not, because male is usually on almost 75% cases, there is a mutation in male if the patient has a bilateral absence of VAS difference. If the female is not a carrier and the male has just a minor variant, then probably we can go ahead. If he has a major variant, definitely again, there is a chance that he will have this problem, and we should not go ahead with doing ART in these patients. And about, there's the question from one of our faculty, Dr. Nachiket Vyas. He says about the ejaculatory duct obstruction. Many times we find that the obstruction may not be at the ejaculatory duct itself, but Mullerian duct cyst or a prostatic utricle cyst may cause obstruction to the ejaculatory duct. Similar case we just did just one day before, just yesterday only. In your experience, what do you find? How many cases of these paramedian cysts or Mullerian duct or utricle cyst causing obstruction results in ejaculatory duct obstruction?
Honestly speaking, I've stopped doing ejaculatory duct obstructions. They are disheartening. They do not cause, many a times, like I think Dr. Nachiket just now said, these obstructions you would never see at the point of ejaculatory duct. They are more of atresia. So when you go explore, we used to do retrograde catheterization and vasography also initially, and we would find that the whole ejaculatory duct on the right side or the left side is atretic. You can't even enter this. So when you try to resect them, you can't resect them and completely open up these ejaculatory duct. Only a cystic swelling at the level of the ejaculatory duct is amenable for a TUR ejaculatory duct, and that too a cystic swelling which is completely obstructing and associated with a low volume ejaculate, which is a very rare phenomena. Even in those individuals where we release the obstruction, it causes a significant retrograde ejaculation and does not give the benefit of an antegrade normal semen sample. So consequently, ejaculatory duct obstructions have some amount of, embryological basis, and they are not amenable for surgical correction and a normal outflow of the semen. That is my take. So I do not do ejaculate just for a differential diagnosis where we do all this just to demonstrate. But at the end of the day, if you ask me whether it is a CBAVD or an ejaculatory duct, would I go ahead and operate? I would explain all these options to the individual. They're better off with an aspiration and an IVF than going ahead and attempting an ejaculatory duct surgery.
Right, because many of these long-standing cases may cause even proximal obstruction, and even doing a Tourette may not help. And sometimes the sperms may not be motile sperms, and sometimes they may not be in good quantity to have a spontaneous pregnancy with these sperms. Anyway, you may require an ART in these patients, even if you have some sperms post Tourette. So I think you are right that most of these patients would not be helped by Tourette in terms of a spontaneous pregnancy with semen. Right. Any of the residents has any question, please? Residents,
yes, sir.
faculty. Yes,
sir. Good evening, sir.
Yes, go ahead.
Sir, I would like to ask, as we know that vas deferens and seminal vesicle formed by the Wolffian duct, sir.
Sure.
So how many cases in which vas deferens and seminal vesicle are absent, sir? In how many cases, sir?
In the sense, I didn't understand your question.
No, probably he is trying to say that that there's a congenital absence of vas deferens because of the Wolffian duct abnormality. Is it that in every patient you have a deficiency of both seminal vesicles and vas deferens, or it is not in every case? That we have already discussed, that it is maybe in few cases there may be seminal vesicles present, and not necessarily that every case has a deficiency of seminal vesicles. Anybody else has any question? Okay, so we will go ahead with Dr. Vasan with the other case scenario. Yes.
Yeah, here is the 29-year-old male who comes with primary infertility of 3 years duration. He is known diabetic on insulin for the last 15 years. He gives history of erectile dysfunction. His semen parameters are again 0.5 ml. pH is again acidic. His FSH is 7, international unit. Testosterone is normal. What is your diagnosis? The reason I put this up is this is a similar scenario with almost similar findings, but the differentiation here is between anorgasmia, anejaculation, retrograde ejaculation, or retarded ejaculation. Let's put it that way. It may not be an ejaculation, it's a retarded ejaculation. So there are some anorgasmics who also have retarded ejaculation. So this is another scenario where you will find people not necessarily only in diabetic population, but non-diabetic population also coming to you with low volume ejaculate, typically having acidic pH. Sometimes the FSH is slightly on the higher side, it's still less than 7.6, which is considered to be the upper limit of normal nowadays from a point of view of non-obstructive azoospermia, and testosterone is normal. So in this kind of an instance, history is very important because you need to go through a complete history. What is the problem? And of course, the differential diagnosis here would be that you found a normal vas deferens and you did not find any abnormality in the testis and your PR is normal. So typically here you do post-ejaculatory urine analysis for confirmation of diagnosis, whether the question is, like I said here, the question is whether this is his normal volume or is it an abnormal volume because part of the semen is going back into the bladder. So that is what you need to demonstrate. So typically what comes here outside is the prostatic fluid, and the seminal vesicle and the vas deferens, which contains the sperm, typically goes into the bladder. So consequently, you need to first evaluate whether there is any sperm in the post-ejaculatory urine. And how is it done? Most importantly, you ask the patient to normally ejaculate, collect whatever, first empty his bladder because you need to collect the urine from the bladder. So first empty the bladder, then ejaculate. Post-ejaculation, you ask him to completely urinate, not give him a small container. You should give him a container sufficient for him to collect his whole urine. And then you need to centrifuge that urine sample, report the sperm in millions per ml. It should not be reported in 2 to 4, 3 to 5 per high power field because then you can't make out. Because typically you would expect sperm anywhere above 0.5 million, then it is considered to be a retrograde ejaculation where there is some present. It can be anything above 0.5 million. So you are first of all collecting all the urine post ejaculation in an individual and then analyzing. Then you confirm it as retrograde ejaculation. Two scenarios will play out there. One, if you find no sperm in the urine, post-ejaculatory urine, then you're looking at a scenario of retarded ejaculation. So that is how you make a differential diagnosis of a retarded ejaculation versus retrograde ejaculation. And most important in retrograde is many of the labs I've seen, they give a small container to collect urine. That should not be. We give a wide mouth container, just like your urine can, you ask them to give a urine can because you're not worried about sterility. You just want to examine the whole urine, and your lab also should centrifuge the whole sample, spin the whole sample. It will take some time to evaluate retrograde ejaculation. Then comes the management of retrograde ejaculation. Historically, people have used urinary alkalinizers or collecting sperm from the bladder, trying to see whether they can harvest the sperm. And the third option is to use alpha adrenergic agents to prevent retrograde ejaculation. All three modalities, your alpha adrenergics to facilitate bladder neck closure, to prevent retrograde ejaculation, your urinary alkalinizing agents in terms of soda bicarb, trying to systematically alkalinize, or third, alkalinizing the bladder content by instilling media into the bladder. All three have been utter failures. There are various protocols. I can give you protocols. We have attempted all these protocols. They have given anecdotal pregnancies. So in terms of reproductive, what are you doing all this for? First of all, are we able to correct retrograde ejaculation because it is an autonomic event? And unfortunately, we are unable to correct retrograde ejaculation, especially if it is because of diabetic autonomic neuropathy. So, or if it is surgical, or if it is because of any trauma to the perineum, we are unable to correct it. Second, can we alkalinize systemically and produce an alkaline urine so that the sperm stays in the bladder in an environment which is friendly for it? No. People have alkalinized. We have alkalinized urine up to about 8. It's a cumbersome process where you give soda bicarb 48 hours before and start giving soda bicarb so that and measure the pH of the urine and try to increase the soda bicarb just before collecting. And many of these people also urinate a lot at that point in time. So it becomes very difficult. And despite that, the sperm somehow loses its acrosome and it is not fertilizable. The third is people have instilled media into the bladder, emptying the bladder, asking him to ejaculate, and then instilling first the media and then asking him to ejaculate and asking him to void the urine with the media which is instilled so that you can collect the media with the sperm and then separate the sperm from it and try an IUI that has the potential of causing problems in the women because you are potentially using urine which is contaminated and then separating. More importantly, it has given very, very anecdotal pregnancy rates. So consequently, in terms of management, is an IUI possible in this individual? No. There is no question of an IUI. We have abandoned this approach, though there are, in textbooks, they describe this. This is like many of our urology procedures which have been abandoned now. So we still discuss about IUI using this method or alkalinizing the urine and other things. So ICSI has been attempted in these individuals, but however the ICSI has been attempted? Only with a TISA ICSI. So many of these people with a typically proven retrograde ejaculation end up with a TISA ICSI. There is no other option for these individuals. Of course, if they come under the category of a retarded ejaculation, where the ejaculation is retarded, that means the ejaculation is not happening completely, then you have various other methods. Of course, it's a method, it's a combination of both enhancing the erectile response, seminal vesicle contraction, as well as psychological inputs. All three is combined to facilitate a better ejaculation, and vibratory stimulation and several other things are used in those individuals to facilitate a proper ejaculation in a retarded ejaculation. So to summarize, a retarded ejaculation can be better managed and probably facilitated for a better outcome than a retrograde ejaculation at this point in time.
Right. A very important case scenario for the residents. With your experience, you know that with retrograde ejaculation, the retrieval of sperms may be difficult and they may not be able to use it for ART. But for the residents, I would tell them that you should know exactly how to diagnose retrograde ejaculation and how to retrieve the sperms. As Dr. Vasan has already said that, yes, one is that you should collect the urine once after the ejaculation, or if you can even instill the semen medium before into the bladder and then ask the patient to ejaculate so that the medium has that presence of sperms if he has retrograde ejaculation. About the retarded ejaculation, I was just thinking about functional obstruction of the ejaculatory duct or vas or seminal vesicles. That is again an entity, which is again probably due to these causes only, which is could be neurogenic because of diabetes or nerve related or post-operative injury to these nerves, which relate, or even drug induced. There are many drugs which can cause functional obstruction of the vas or seminal vesicles, and the patient is not able to ejaculate completely. And that can result in low volume ejaculate, and that also should be kept in mind when taking a proper history in these patients, which can result in some of these patients with have low volume ejaculate. So retarded ejaculate, as you said, is not probably the delayed ejaculation, which usually we see it as retarded. What you meant probably is the ejaculate which has not been fully ejaculated.
Yes.
So it's not a delayed ejaculation, but it is ejaculation which is a partial ejaculation.
Yeah, that's why it's called retarded ejaculation. That's the term we use nowadays. So yes, I agree with you.
Yeah, because there is another term which is called delayed ejaculation, where the patient is not ejaculating at the right time, and it takes much more time to ejaculate. So here probably there is some kind of functional obstruction where he is ejaculating partially and not completely. Or there may be even complete loss of ejaculation in some of these patients due to functional obstruction because of drugs, nerve injury, trauma, or post-surgery, or even diabetes. Any resident, any question from the residents or faculty? Because this is a very important case scenario, right? There was one question from one of the faculty, what is the cost of CFTR test? Sir, can you say exactly?
8,000.
8,000, yes. So it costs around 6,000 to 8,000 rupees for those 27 tests which are available in the market. All right. So residents, do you have any query regarding this low volume ejaculate resulting because of retrograde ejaculation or retarded ejaculation or a kind of functional obstruction of the ejaculatory duct or vas or seminal vesicles, right? That's a very important case scenario. Okay, sir. So we can go ahead with the fourth case scenario.
Here is a 27-year-old male who comes with primary infertility of 2 years duration. He shaves his beard and mustache once a week, which makes him very happy. His semen analysis volume is 1.2 ml, pH is 7.6 alkaline, azoospermia. Bilateral testicular volume is 6 to 8 cc. There's no evidence of varicocele. Epididymis and vas difference are normal. His FSH is 1.1 international units. So typically, I put up this case as Shivam was discussing right in the beginning, just to say that having a beard and mustache sometimes makes these people feel very normal. But the catch is that he's shaving only once a week. That means he's got sparse hairs and the growth is very low. So this is typically a case of hypogonadotropic hypogonadism. So essentially, why? Because when you examine this individual, you would probably look for signs of poor virilization, and the ejaculate volume is low, and the pH is normal, which is alkaline, and also FSH is low. Of course, we can do the other hormones which are corroboratory evidence in terms of your LH and testosterone and all that. So these are the typical scenarios which you will see when you look at testicular and seminal characteristics in azoospermia. Depending on the type of azoospermia, if you have a spermatogenic failure, then you would either see small testis or normal testis. You would see normal ejaculate volume and a normal pH. Whereas if it is hypo, you would see small size testis, low ejaculate volume and a normal pH. If it is obstructive, again you would see normal size testis, either normal or low pH, and an ejaculate volume, which is again normal and normal volume. So typically in this case, in a hypo, you would see a low ejaculate volume, normal pH, and a small size testis. Now again, what is a small size testis is very difficult to define because there are various studies which have been done. Typically, people consider a small size testis to be less than 3 cc. But there are a lot of hypo where you will see it not typically CCC. So it can be 5 cc, 6 cc, still end up in a hypo. So I don't have a cutoff where I can give you a normal cutoff which is classical and representative of a hypo. But definitely a testis which is less than 3 cc is considered to be hypo. Now, what are the what are the causes of azoospermia, not NOA, in hypo? It could be either congenital or acquired. If it is a congenital, we are looking at a Kalman syndrome or normosomic hypo or a Prader-Willi. And if it is an acquired, it is a pituitary tumor or, like I said, steroid abuse, which I presented in the first case, which is another case of a hypo. So what is the normal hormonal, hormonal profiling you will do? Typically, like I just presented, you do a FSH, LH, and a testosterone. The values are normally FSH and LH are less than 1.2 international units. Testosterone is less than 3 nanogram per DL. This is what you would see. And how would you, what are the considerations in this patient? What are the prognostic factors to response to medical therapy? Obviously, this patient needs to be treated. He needs to be medically managed. And if it is a medical management of hypo, what is the HCG dose, duration? What is the HMG dose, duration? And what is the role of ART? These are the basic questions we need to answer if we are looking at treating these individuals. So what are the predictors of treatment success? An increased baseline testicular volume is the first predictor of success. What is the increase in baseline we look for? At least a 20% volume increase, depending on how you measure, if it's an ultrasound-based measurement or a Prader or pedometer measurement, whatever you're comfortable with, or a bead measurement. But if there is a history of, this doesn't apply if there is a history of cryptorchidism in that individual, because in that individual, you will not see a baseline testicular increase. If there is no history of sexual maturation also, you will not see a testicular volume increase. And so these are the other correlates which should match. That means there should not be a history of cryptorchidism. There should be a history of sexual maturation. There should not be a history of testosterone replacement therapy. If you have all these, then this will not happen. So the predictor of treatment success is based on a normal individual who doesn't have these three parameters. So what is the basis of hormonal therapy in hypo? LH acts on LH receptors, leading to intratesticular testosterone production, and consequently Sertoli cells contains FSH and androgen receptors. FSH and testosterone acts on initiating and supporting spermatogenesis, as I showed you in the initial slides. So these are the basis of stimulating LH Leydig cells and stimulating Sertoli cells at a later date, where you start with HCG and then you add HMG. So the dosing is 1,000 to 2,500 units, depending on the testicular size and age of the individual, depending on the weight of the individual. HCG twice a week for 8 to 12 weeks, which is called the induction phase, where you expect the testicular volume to increase. The induction of Leydig cells should happen. And then once the induction happens, you can give FSH 75 to 150 HMG, or some people have used recombinant HMG up to 3 times a week per week for up to about 18 months, which is what is the duration. So what is the role of ART? If spontaneous pregnancy does not occur after 20 months or 8 months after achieving sperm concentration of more than 5 million, then you should consider ART. So what is the ART you will consider? If IUI is considered, if sperm count is more than 5 million per ml, ICSI is considered if it is less than 5 million per ml after 1 year of treatment. If it is more than 5 million per ml, but no pregnancy after 2 years, then again ICSI is considered. So this is the caveat where, because we need to know, one, how long to treat, what is the outcome expected, when do you intervene, because they may never normalize. They may never have a normal sperm count parameters as per WHO parameters. So this is the caveat where we look at how to help these individuals. The ultimate goal is to, one, because many of these men have secondary sexual characters which are developed. It is only the fertility we are considering normalizing. So consequently, there is a need to add on ART to these individuals and facilitate a faster pregnancy. So spontaneous pregnancy usually should occur within 20 months or after 8 months of achieving sperm concentration. If it doesn't, then you start considering ART. So that is the case scenario.
Thank you. Again, it's a very important case scenario. So I will just add a few comments on it. Now, number one is azoospermia as a whole. This hypogonadotropic hypogonadism can account for about 2 to 3% of these cases of azoospermia, and about 2/3 cases are usually non-obstructive azoospermia, and 1/3 30 to 35% cases with obstructive azoospermia. As Dr. Vasan has rightly said about the secondary sexual characters, that is very important while taking the history in these patients. And the testicular volume may be sometimes may be normal also if these patients have an acquired kind of hypogonadotropic hypogonadism, which they take because of maybe of drugs or maybe trauma or head injury. All these may cause hypogonadism in these patients. So they may have normal testicular volume also. And some of these patients patients, though most of these will have low volume ejaculate, many of these patients may have an ejaculation complete. They would not ejaculate at all, many of these patients. And when you treat these patients, they start ejaculating and producing semen. So again, patients of an ejaculation can also be of hypogonadism. And about the treatment of these patients, yes, most of these patients of congenital variety, we start with SCG first, and then when the testicular volume becomes of an optimum size, then we start with add FSH. But in the patients with acquired variety or adult onset of this hypogonadism, we can combine both the two together from the onset to have the fertility. And about the number of sperms, it has been seen that even with 5 million sperms in these patients who are treated with gonadotropins can have a spontaneous pregnancy. So it is not necessary that they should reach to 15 million mark to have pregnancy. Many of these patients may have a spontaneous pregnancy with 5 million with good motile sperms. But yes, as Dr. Vasan has rightly said, many of these patients, even after 2 years, if they do not have pregnancy, then we have to do ART in the form of either IUI or ICSI, or this may be added with TISA also. So any questions from the residents and faculty? Gagan, Yadav, Sarses, Sayam, anybody? Because this again is a very important case scenario. Hypogonadotrophic hypogonadism, how to diagnose it and how to treat this patient is a very important thing to understand. I think we can go ahead with the next case scenario. Right.
A 34-year-old male comes to primary infertility. Hello?
Yes, your voice is a little interrupted. Yes.
Yeah, 34-year-old male comes with a primary infertility of 10 years duration. Normal volume, alkaline pH, azoospermia. Bilateral testicular volume is 10 cc. He has bilateral grade 3 varicocele. Epididymis and vas difference are normal. FSH is 21.9, testosterone 2.7. So this is a typical case of high FSH, low testosterone. So obviously we are looking at a non-obstructive sort of an azoospermia, or it could still be an obstructive azoospermia. Just to give you an idea where why the testis shrinks is basically because of the the increased FSH, which sort of decreases the testosterone and decreases the inhibin, and consequently the testis shrinks, and consequently there is a negative feedback mechanism. And this is the normal FSH, how the testicular growth gets impacted in a case of high FSH. That's why I put this up. So one of the most important things which I wanted to present was that normal FSH does not necessarily mean normal spermatogenesis. So normal FSH does not mean many men with primary testicular failure can have normal FSH, because FSH per se is a very inconclusive test. You could have a normal FSH with an abnormal spermatogenesis, high FSH which have patchy or a normal spermatogenesis. So because essentially testicular failure means it's a very misrepresented term or misunderstood term, because when we say failure, we mean that there is nothing happening in that testis. But unfortunately, nowadays we are moving away from a term called testicular failure to testicular dysgenesis, basically because this doesn't represent the fact that testicular failure patients can have focal spermatogenesis present. So FSH per se does not represent anything. It is just a guide of what is happening, but you have to look at corroboratory evidence before you can decide whether there is an obstruction or a non-obstruction. So typically, what is a primary testicular failure? Primary testicular failure means all areas of the testis have no sperm production. But we know that in primary testicular failure, you could have people with many sperm. That means when we say primary testicular failure, if we are basing our opinion on the basis of FSH, we know that high FSH, there are men with many normal sperm production, patchy sperm production, or no sperm production. This has been the challenge in diagnosing non-obstructive azoospermia versus intratesticular obstructive azoospermia. Azoospermia can be two types, where you have a full epididymis, where there is an epididymal obstruction and an azoospermia, which is classically recognized by your palpation and other techniques. But there is also an azoospermia where you have obstructive azoospermia, wherein there is an intratesticular obstruction, and that needs to be differentiated from a complete non-obstructive azoospermia, where there is no obstruction and no spermatogenesis. So that is the challenge, because testicular failure does not mean no sperm. So what are the challenges in azoospermia? So you have azoospermia with fructose positive, which means normal volume. You have typically an obstructive, or where we consider small testes, flat epididymis, high FSH as primary testicular failure, or we are equivocal, where we don't know what is happening. These are the three scenarios which we normally look for. So in an obstructive, obvious obstructive, we know that there is a good sized testes, firm testes, full epididymis, normal vas deferens, fructose positive, high chances of an epididymal obstruction. If we want, we can do a needle biopsy, an FNAC, confirm that there is spermatogenesis, then proceed with a VA or a PISA-ICSI as the patient has been counseled. Because one is you can do a microsurgical bypass or give him an option of a PISA-ICSI procedure. Or you don't need this needle biopsy. You can directly explore VEA, VVA, no prior vasography needed, because there was an era where people used to do vasography to check the vas patency. Everything can be done at the same time. So this is a case which normally we encounter. Many of us are comfortable doing these cases, but there are challenges even when you do cases. There may be a scarred epididymis because of which, or a cystic epididymis. So an ultrasound will facilitate some of your decision making. The other extreme is where you have, these are easier to diagnose, very small testes, flat epididymis. Then you know that again, biopsy may not be required unless the patient opts for an ICSI. Because here, you know, you are not going to normalize him, give him a normal spermatogenesis. So if this comes in, why have I put up this? This is purely an economic consideration. A patient who is poor, who is looking for a baby, we know the option for him, even if we are going to offer him a surgical procedure, the surgical procedure offered in this individual would be a testicular sperm aspiration or a microtesticular sperm extraction, and then an ICSI. There is a considerable cost consideration with no guarantee of a success. So consequently, we need to discuss with him a donor insemination or an adoption right in the beginning, because this may be an option many people consider. So this is something which we always normally follow. Only offer this to individuals who are willing to go down the path of both who are sound economically, as well as willing to take the chance that it is not going to be 100% successful. So these are two direct criteria where we have clear-cut strategy laid out. The most important thing is the equivocal category, where we are not sure. Maybe my palpation doesn't show me whether it is a full epididymis, testis looks probable. So whether in this kind of an instance, testicular biopsy is needed, that is what. And if it is needed, whether it should be bilateral, whether it be multiple, whether it be microbiopsy or a needle biopsy. So these are challenges which I'm sure we can go on discussing endlessly, because these are very, very critical phenomena. So the question again here is, what's the purpose in it? So one is, if an individual in this kind of a scenario where it is equivocal is not considering his own biological child for economic reasons, then there is again no need for a biopsy in this kind of an individual, because you can directly proceed with a donor insemination or an adoption. Because he doesn't have the economic ability to go ahead with the procedure. Only in an individual who says, I have the economic ability, provided I have the guarantee of finding a sperm, then I would do a 4-quadrant needle biopsy to find out whether he has focal spermatogenesis. Because in that kind of an individual, if I find sperm easily, then I can channelize him for an IVF. If I fail in that process, if I don't get sperm in that individual, then in the next step, if he is insisting, because the chances of finding sperm in individuals where they have failed 4 or 8 quadrant, I will present you a series of slides going forward, decreases as we go along with the number of random samples we take. So I will get back to this, which is a critical phenomena, in the next couple of slides. So the non-obstructive azoospermia, we all know, has multiple components: Y chromosome microdeletion, Klinefelter, cryptorchidism, post-infectious. You have various things. So what is the approach in a non-obstructive azoospermia? First is a differential diagnosis of azoospermia. Confirmation of non-obstructive azoospermia is due to spermatogenic failure. So that is the first thing. So how do we do that? So first is a hormonal evaluation. You can have your FSH, LH, estradiol, testosterone, because you want to estimate T ratio, and SHB levels, which also has a negative feedback correlation with the testicular failure. And you have your karyotyping, Y chromosome microdeletion in azoospermia. How will you prognosticate a case of nasospermia? One is your testicular size, karyotyping, Y chromosome microdeletion, FSH, testicular biopsy, varicocele, people have associated, low testosterone or abnormal T ratio. Now, what is the incidence of what is the necessity for a chromosomal or a Y chromosome deletion? Because we know that 10% have chromosomal numerical abnormality, approximately 8 to 15% can have Y chromosome microdeletion, because these are very important factors for counseling an individual on the risk of a future offspring developing these same chromosomal abnormalities, or higher abortion rate, or failure of fertilization, or a failure of a micro-TSA procedure. So is there any cutoff or testicular size below which you will not offer sperm retrieval? There's no lower limit of a testicular volume for the absence of spermatozoa has been identified. No statistically significant difference in testicular volume between patients with retrievable spermatozoa and those without. Small testicles generally have poor global spermatogenesis. Small testicles can have absent focal spermatogenesis. So that is one of the correlations. Would you offer SSR to men with Klinefelter syndrome? We know that Klinefelter syndrome can have 61% of patients can have focal spermatogenesis and have a pregnancy rate of 40%. So yes, so that is something which is now known. Would you offer sperm retrieval in non-obstructive azoospermia with Y chromosome microdeletion? We know that AZFA and AZFB has no chance of sperm retrieval. Only AZFC has sperm chance of sperm retrieval, and genetic counseling is indicated. So this is what it is. So because of germ cell aplasia, there is no sperm retrieval chance in AZFA. Maturation arrest, no retrieval chance. And only in C, you have hyperspermatogenesis, 70% chance of sperm retrieval. There is also AZFD now, but again, that is not significant enough for us to discuss it. Can we predict if sperm are present in any way? We have looked at testicular size, histology of ejaculate sperm, or the testicular histology, FSH level, which are the correlators. We all know that viewing a combination of factors, there are various predictive factors which are available. Testicular volume has a very low sensitivity and specificity. FSH again has a low sensitivity and a specificity. Inhibin again has a low sensitivity and a specificity. Using a combination of factors of testicular volume, hormones, Doppler sound imaging, your specificity increases up to about 89%. Again, to summarize, there is no one test which can tell you with high sensitivity and specificity, predictivity of this is the holy grail where we cannot predict whether sperm is present. Does high FSH reduce the chance of SSR? We all know that when the FSH is less than 15, somebody did, I think this is Ramaswamy Ranjit's group, which did a study wherein they found the highest rate of sperm retrieval with FSH of 31 to 45, which defies the logic that high FSH is a marker for poor spermatogenesis. So role of testicular biopsy only tells about predominant pattern of spermatogenesis, does not give any clue of focal spermatogenesis. In 20% of patients of focal spermatogenesis would have been missed with unilateral biopsy. So if at all you do a biopsy, it has to be bilateral, may compromise already limited sperm production in NOA by causing scarring. The accuracy of predicting TISA success is only 74 to 84% if at least one spermatozoon was observed in the histological examination of a random testicular biopsy. So consequently, an isolated diagnostic testicular biopsy is not recommended in men with NOA. A significant proportion of men undergoing micro-TISA will have successful sperm retrieval irrespective of previous histology or previous unsuccessful surgery. So, as you can see in this slide, when it is hypospermatogenesis, you have a high sperm retrieval rate. When you have maturation arrest, it decreases, but it is not zero. And we certainly cell-only syndrome, you still have, these are the various groups which have worked on this, you still have a sperm retrieval rate. So consequently, finding sperm in non-obstructive azoospermia has always been a challenge. So what is the process now? Do we do microdissection for everybody? Do we do FNA mapping for everybody? What do we need to follow? If it is FNA mapping, how many sites are you going to sample for finding the sperm? So this is what was shown by this group which worked on this, as how many testicular mapping you do to find. So as your number of sites increase, as you can see, up to about 14 to 15 sites, people have done up to 18 sites, then only it levels off. So the chance of finding the sperm progressively increases up to about 15 to 16 FNA sites of the testis. But as you can see, you hit a sort of a plateau above 8 or 9 sites. So now what we believe, what I believe, and also some groups are talking about, is directed micro-TC. What is a directed micro-TC? We do 8-quadrant FNA mapping bilateral. If we identify sperm, freeze, and we would have discussed with the patient at that point in time. If we don't find sperm in 8-quadrant FNA mapping, chances of finding sperm with a directed micro-TC in that given individual is only 20%. So if patient has agreed to it, then you proceed with a micro-TC, because his chances of not finding sperm is 80%. That is what I've written here, 15%. And the patient can go ahead with a donor option, because this reduces the cost of an expensive micro-TC procedure. Secondly, it reduces the chance of hypogonadism developing, because micro-TC is known to cause some amount of hypogonadism and in these individuals. So we are looking at minimizing testicular trauma. So that is what I'm getting at. So the role of FNA mapping and directed micro-TC on the basis of sperm detection rate is what is evolving as a strategy in non-obstructive azoospermia. So this is something which I don't think I'll discuss with us. So the varicocele treatment has also evolved. We will look at it. And before we do directed micro-TC, is there a role for hormonal manipulation in non-obstructive azoospermia? Yes. High basal levels of endogenous gonadotrophins can reduce the relative amplitude of both FSH and LH, leading to low intratesticular testosterone. So consequently, neither baseline testosterone level, non-response, nor hormonal therapy appears to affect overall sperm retrieval, clinical pregnancy rate. This was the old school of thought. Now we believe there are several studies which have been done. I'm taking too much of the time today, so I'm just going to rush through these slides. So we believe that having a target level of FSH 1.5 times the basal, or a testosterone of 6 to 8 nanogram per ml is very important, because we believe that it significantly, whatever regime you follow to improve the testosterone, either you give clomiphene or you give clomiphene for HCG, HCG with HMG, or HCG with, irrespective of whatever regime you want to use, if you achieve this target, your sperm retrieval rate either with an FNAC or micro-TC increases. And this is the algorithm we follow to improve the testosterone like I said, 6 to 8 nanogram, depending on what you believe is the T ratio. You can use any of these algorithms. So most important caveat, when you have used this algorithm and improved the intratesticular testosterone, always check for the sperm prior to SSR. That means on the day of the procedure, you do a semen analysis, because 20% of NOA can have sperm in the ejaculate during the course of treatment, because the spillover threshold is 3 sperm per spermatogenic seminiferous tubule. So the policy of checking for spermatozoa in repeated sample and also on the morning of SSR may save the patient of an expensive surgical procedure, and he may get the sperm, because you're not normalizing individuals please bear in mind, you're not normalizing individuals. You are trying to just get sperm from a testis. If you are getting the same sperm from the ejaculate, why not cryofreeze it? So ideally, the whole purpose of treatment of non-obstructive azoospermia is to evolve a strategy of low cost, OPD procedure, painless, minimal testicular tissue removed, high recovery rate, no long-term testicular damage, and reproducible. These are the caveats for an SSR, and that is why we are looking at how do we manage a case of non-obstructive azoospermia. The challenges are, is it non-obstructive azoospermia? Are there any markers to recognize there is sperm? Like I said, there is no definite marker, but we have a high possibility by using a combination markers. Then what are we going to offer? Are we going to offer a direct TSA for this individual? Are we going to offer TSA for this individual? Or am I going to do a micro TSA for this individual? Every case of non-obstructive azoospermia, let me do a micro TSA. This is a debate which is ongoing. I don't think I'm going to be the jury and decide today, but I'm just opening up for thinking. My view is we should be looking at a directed TSA, not offer micro TSA for all individuals. And like I said, medical treatment before micro TSA, even in Klinefelter syndrome, is known to produce good results. And all treatment, wherever you are offering sperm retrieval, should have medical treatment. And not all sperm retrieval procedures are the same. That is why this debate is going on, because this is the least invasive procedure. This is the most invasive procedure. And obviously, we want to avoid the most invasive procedure. And we all know that most invasive procedure has the best success rate. But if we can optimize the sperm before the most invasive procedure and do the minimal invasive procedure, then that is the most ideal way to go about in these kind of scenarios. Thank you very much. I know I've covered a lot, but I thought I will just stop here because it goes on.
No. Thank you very much. You covered the whole thing in maybe a few minutes only, but the residents may not have understood everything. So for the benefit of the residents, I would just summarize everything. Maybe I will try to summarize in a couple of minutes. So what we are discussing here is a patient who has a normal volume ejaculate and he's presenting with azoospermia, right? So we have already discussed the low volume ejaculate with ejaculatory duct obstruction and hypogonadism and congenital absence of vas deferens. So here it is a normal volume ejaculate with azoospermia. There could be 3 scenarios, right? One is a typical case of obstructive azoospermia where there is normal testicular volume, turgid epididymis with a normal FSH level. So all things going in favor of obstructive azoospermia. There is no need of doing a testicular biopsy in these patients, and we can go ahead doing a microsurgical vasoepidermal anastomosis. As Dr. Vasan said, you may do a needle aspiration biopsy to confirm it, or you may not do a needle aspiration. Just go ahead, and when you just transect the epididymis or at vas, you can just show the presence of sperms there and go ahead with the surgery, reconstructive surgery after knowing the vasal patency. So this is a typical case of obstructive azoospermia and how you treat them. And then you have a typical case of non-obstructive azoospermia where the volume of the testis is low, the FSH is quite high, and the epididymis is quite flat, and a normal volume of ejaculate. So this is again a very typical case. You need not do a biopsy in this patient. You need to counsel this patient whether he wants to go ahead with assisted reproductive technique or not. If he is not going, then advise him donor insemination or adoption. because it may be due to economical reasons also. So if he is wanting IVF ICSI and sperm retrieval, then you do a genetic testing in these patients. If this patient has a Y chromosome microdeletion, which is AZFA-B, no need of doing any sperm retrieval because there will be no sperms. If it is AZFC, then you go ahead with doing a sperm retrieval in these patients. So this was a typical case. Again, as Dr. Vasan has rightly pointed out, in these patients, if you have a low testosterone level, so before doing a sperm retrieval, it is good that you improve the intratesticular testosterone level in these patients by either giving clomiphene or SCG injections, so as to improve these chance of having a more presence of sperms in the sperm retrieval. The third scenario is the most challenging scenario, where you have an equivocal case where the testicle volume may be normal, it may be slightly lower on the side, or the FSH may be in the normal range. The epididymis, you don't know whether it is turgid or it's flat. It may be normal, just epididymis. Here, what is the role of testicular biopsy? Again, in today's era, when we are going towards more of cryopreservation and doing assisted reproductive technique, a simple singular testicular biopsy is probably obsolete nowadays. If the facilities are available, we should always do a bilateral multiple testicular biopsy in these patients with facility of cryopreservation and going ahead with assisted reproductive technique. So the best way is doing a testicular biopsy, either by needle aspiration or a biopsy. And then if you have embryologist, just see whether there is a presence of sperms or not. If there is presence of a sperm in the first biopsy, you may not do multiple biopsies in this patient. And then it is a clear-cut case of patient with normal spermatogenesis. If you do not find, you need to take multiple testicular biopsies and then look for presence of sperms. So again, which type of sperm retrieval and what are the number of testicular biopsies, again, would be a challenging thing. And whether what is the predictive factor for finding of sperms in a non-obstructive azoospermia could be, again, challenging. So again, as Dr. Vasan has said, that the multiple factors, if combined together, will give more prediction. So if we can develop a nomogram, which includes FSH value with testicular volume and all these, then we can have more prediction. And people are working on even biomarkers. So there is a research going on of mRNA testicular expression, which can give you more prediction whether the testis has presence of sperms or not. So that is probably maybe the future. Again, I think that was, if any of the residents or faculty has any query or any question, please go ahead. Gagan, Sanjay, Sasej, any, if you have not understood anything. Yes. Yes, Angajol, do you have any question? Okay. I think they do not have any other question. So because the time is also running out, so I would thank Dr. Vasan to have spared his valuable time with us today, and definitely the residents must have benefited a lot with your deliberation, and that was wonderful. Thank you very much, and thanks to all the residents, faculty members, and all the viewers who might have joined us today. So thank you very much, sir. Any last comments, sir, and then we'll wind up. Any message to our residents who might be interested in andrology?
What would I would like the format where they present a case and probably we take it from there. It may be a little bit better, so that if they can, present the case, then it becomes more interactive, so that it may make more sense. Because here, what happens is, I have never interacted with them, so I don't know whether I'm going overboard in somewhere, and so that is the challenge I have.
Right, exactly. Because if they present, probably they would be more involved in the whole case.
I think what we should do is maybe 2 presentations of mine and 2 presentations of theirs.
Of
so
the
that,
residents.
yeah, so something like that.
So that we know that they are not sleeping and just right. So thank you very much, sir. And Dr. Vasan is a very popular and very experienced andrologist, and he is having fellowship programs in andrology also. So all those residents who are interested in andrology, you may interact with Dr. Vasan. And again, now Dr. Vasan, myself, and many others, we have again are in a committee where we will try to bring up more centers of andrology and try to bring up more fellowship programs. So thank you very much, and thank you, sir.
Thank you.
Thank you, Dr. Vasan.
Thank you very much.
Thank you, sir. And good night to everybody.
Good night.